They always ask, does prostate size matter? Perhaps yes, maybe no. Let's look into this dilemma, which always confuses a patient and many people around, that what matters in a prostate. Let's look at the prostate. So when you look at the prostate size, it's important for us to understand what the prostate means. That means when you know your prostate, you can know more about it as time goes by. Let's look at the prostate as a walnut-shaped gland that undergoes hormone changes beyond the puberty and is most specific in adulthood. Beyond 40s and 50s, as the hormone changes, there are multiple changes which happen in the prostate. It is being at the most important junction of the urinary and the accessory sexual passages and is therefore pivotal as a control checkpoint. That means the location where it changes brings about a huge difference. And the difference is very silent and progressive, which happens over decades of maturation towards the geriatric or the elderly age group. Prostate, in a common language, could actually be a trapdoor that controls the urinary passage at the outset as a voluntary urination or voluntary voiding happens around when the bladder pressure rises. That means when the bladder pressure rises, as the bladder fills up to near completion or the size where the bladder can hold the maximum, you feel like passing urine. The bladder then contracts and attempts to push the urine out. The outlet opens and the urine comes out. In other words, the prostate could be a trapdoor through which urine comes out, which means the prostatic urethra could be a very narrow pipe from where the urine comes out as the bladder outlet opens up when the bladder contracts. This entire change which could happen in the prostate is a hormone-related change that happens. So the changes also are defined as small or a big prostate. For one and all, the prostate has been best measured by two important parameters which should not confuse us. Number one, the size of the prostate. And number two, serum PSA, a blood test. So let's look at the size. The size is measured by ultrasonography. Ultrasonography is done by a specialist radiologist or ultrasonologist who actually measures the size of the prostate and the properties as visible on imaging. That means he looks through the window of the full bladder and he imagines the prostate size, which he measures by parameters. He also looks at the changes happening in the bladder in terms of bladder wall thickness, the amount of urine you can hold before passing urine and amount of urine you hold after passing urine, called the post-void residue. He also looks at your kidneys and looks at the changes happening as a result of a bladder outflow obstruction or a bladder outlet obstruction, which means the urinary passage is getting choked by changes in the prostate, which could bring about back pressure changes in the bladder and in the kidney. That all is measurable as an image, and that is called as ultrasonography or a sonography. Size is measured best on ultrasonography, where they accurately attempt to measure. But remember, the measurement can always differ umpteen times in a day, week, or a month, because the angle on which the prostate is measured gives an approximate idea, 2 centimeters and 2 grams, as to what the measurement is happening. PSA, prostate-specific antigen, a surrogate marker which is produced by the prostatic epithelial cells that is measured in the blood as a marker. This marker can be raised in the blood from the normal 0 to 4 nanogram percent to very high levels beyond 4 to 10, 20, 40, and 80, even in very severe inflammation called prostatitis and in cancer prostate, and also in some disease states. So PSA, a marker which is measured in the blood, could bring about ideas about changes happening in the prostate with or without complaints that a patient may have. Coming to size and what the prostate does to you matters most to a urologist and finally to you too. So when does that happen? As the prostate in the mature middle years beyond 40s undergoes the hormone changes that brings about its growth in a subset of individuals that is most needed to understand as the age-related changes, which is called as hyperplasia or BPH, benign prostatic hyperplasia. That means increasing size as the number of cells in the prostate increases, the prostate decreases in size. So what the prostate could do as it increases in size internally and externally matters. Internally, it matters because it causes an occlusion or an obstruction to the flow, which brings about a bladder outlet obstruction. Externally, it matters because the prostate is increasing in size, and that size increase is measured best by a sonologist and can have clinical connotations. So growth internally and bringing about a change in the caliber of the urethra, which is called as a prostatic urethra, that is internal, thus compromising the urinary passage, brings about the slowness or decrease in the speed of urine. These are progressive changes where an obstruction to the flow of urine could be measured as a narrow stream of urine, taking time to pass urine, perhaps not emptying the bladder completely, and therefore straining to start, straining to end, and probably dribbling in the end. So growing in size may not necessarily occlude the urinary pipe or the urethra, is what is an important matter. Though a gentle rule of thumb is, if the prostate happens to be increasing in size in all directions, as measured by the sonography as an increased size in prostate, it will also be changing the configuration of the urethra internally, thus bringing about a prostatic occlusion to the narrow urethra or the prostatic urethra at the beginning of the urinary passage. So yes, what the prostate does to you actually matters to the changes which are gradually and progressively happening internally. Friends, does the prostate size matter? Perhaps yes, and maybe no, is what I said. In other words, a small prostate can cause an obstruction to the urinary flow and give a huge amount of symptoms. In other words, the prostate did not grow in size for the somnologist to measure the size of the prostate being large, but it could be causing internal occlusion, and the growth is primarily internally in terms of a median lobe enlargement, in terms of the lateral lobes enlarging, finally causing the obstruction to a very narrow urinary pipe that you know how narrow it is. The large prostate may sometimes not obstruct even, and therefore may cause minimal symptoms. So prostate is enlarged, but the configuration has been such that the internal, the urethra does not probably get occluded. So larger the prostate, obviously more the blood supply of the prostate, and therefore its chances of bleeding in the background of antiplatelets or blood thinners, which a lot of patients do take in their cardiological background where they've undergone angioplasty and cardiac bypass, more so when they're straining to pass urine and more so when they're constipated, could happen in a very enlarged prostate where straining can cause spontaneous bleeding because the prostatic size being large, the blood supply of the prostate can be large. So size, then therefore what matters? What matters is the internal changes that is brought about by the prostatic configuration, and that brings about the symptoms that you complain to your urologist. The internal changes are occlusion to the urinary passage or the urethra, which leads to the so-called obstructive changes in the flow of urine. The obstructive changes are hesitancy, where you take a longer time to pass urine. The stream and the flow of urine probably gradually goes down, and as the prostatic flow is getting obstructed, you find that you are not able to empty your bladder completely. You take a long time to empty your bladder, and as a result of which, your bladder is undergoing the brunt of it and becomes irritable and makes you run again and again. So the changes in the occlusion of the urinary passage is a very silent change. The changes of obstruction to the flow of urine is again very silent, slow, and progressive, which happens over days, weeks, months, years, and decades, which gradually changes around. It can be missed in a very busy life and the life of elderly people and geriatric age group, where a lot of other changes are happening. And those changes are sometimes taking a precedence in terms of bone changes and brain changes and mobility issues and the diabetes and blood pressure, other aspects which happen. So what matters is how early one is able to identify the obstruction to the flow of urine that results from the occlusion of the urinary passage. In other words, what matters is identifying oneself by the symptoms and complaints that you could have when the prostate is undergoing a parallel change from 40s to 80s. What also matters is the changes that are picked up in a health checkup to enable to understand our state as evaluated by a urologist. Finally, what matters is look before you leap, and what matters is identify before it's too late. In other words, the urologist unravels the mystery by evaluating you with an examination and an evaluation. The examination is a digital rectal examination to assess an approximate size of the prostate and its configuration to give an idea whether a prostate is suspicious or looks like just an enlarged prostate, or is it undergoing a tenderness and difficulty of a prostatitis. Finally, he does a uroflowmetry and identifies the flow of the urine, and thus identifying what the small or the big prostate is doing to your flow. That means there are continued progressive changes which are happening that can be slowed, changed, improved, and thus treated, and finally cured if your urologist sees you in time. So to identify that, let's look at the prostate and the prostatic configurations. On the left side, you see that the prostate is also growing into the bladder. The growth has gone into the bladder as marked on the graph A, where the prostate lateral lobes are still separated. So the urinary passage can come from the bladder through the enlarged prostate, which could actually occlude the whole bladder outlet. And the urinary passage at the level of prostatic urethra is not completely choked, but the bladder outlet is getting choked by a median lobe going into the bladder. Let's look at the lateral lobes in the slide B. where the two prostatic lobes are gradually occluding the urethra. That means from both sides, the urethra is undergoing an occlusion. Now, that's a 2D figure, but in 3D, it brings about a configuration change of the narrow urethra, which commences at the level of bladder neck and the prostate. And finally, there could be a trilobar prostate, where the prostate could enlarge from both sides and could also enlarge in terms of growing into all locations, including the inside of the bladder, called as the intravesical enlargement of the prostate. So prostatic enlargement can happen in all directions. The direction which brings about an enlargement measurement by the ultrasonologist is a measurement of the larger configuration and the median lobe which enlarges. Let's look at the median lobe enlargement. A median lobe enlargement cannot be measured by the digital rectal examination because it's growing inward, internally into the urinary bladder, which is a receptacle that controls urine and through which the urine comes out. So it's actually choking the bladder outlet. Look at the median lobe enlarging completely into the bladder. So that kind of a median lobe enlarging into the bladder could be either isolated or could be a trilobar prostate where the lateral lobes are also enlarging but below the level of the bladder neck. So this enlargement, which is showing that the prostate is gradually enlarging, an attempt to a medical management many a times may fail in a symptomatic patient where you want to give him relief from the urinary flow. So the measurement of the prostate by a sonography gives a lot of ideas. It gives an idea about the approximate dimension of the prostatic size, gives us a dimension of the median lobe, which is enlarging and choking the bladder outlet. It gives an idea about the bladder wall thickness and the mucosa, the trabeculations, and the various diverticulae which form as a result of the brunt taken by the bladder. It also gives us an idea about the kidneys, which are taking the brunt as the pressure goes back into the kidneys, and that could lead to a silent changes in the kidneys around. So prostate undergoing a change in umpteen ways and umpteen directions is picked up also by another important test called the uroflowmetry. Friends, uroflowmetry is the flow of urine. Measurement of the flow of urine, or metry is measurement, flow is the speed, and euro is urine. So measuring the flow of urine when in full bladder gives us an idea as to how good the flow is. Somebody who is on a younger side, whose prostate is not occlusive and not enlarged, could actually be passing urine with a great flow. If you close your eyes and imagine the way you pass urine on a commode or on a toilet, it's about a great flow as it starts. It continues to be there and then gradually goes down, and there could be some post-void dribble. At the end of it, your urination is completed. That's where we measure a post-void residue. Let's look at an example and few examples. That's Mr. Pradeep, who actually passes urine with a mild straining curve at the end. But if you look at the large picture, he has an approximate bell-shaped curve with a minimal post-void residue of only 15 ml. So residual volume in the background of a good flow with 0 to 50 ml of residual volume is completely wonderful. I call uroflowmetry as an ECG of the bladder. In other words, if you want to test your heart, the cardiologist would only do an ECG and know all about you. And he could then take directions on moving into an angiography and proceed. Similarly, if a urologist wants to know what is the small or the large prostate doing to your bladder and your outlet, he does a uroflowmetry. He measures the flow of urine across the bladder outlet. That's an ECG of the bladder, which like a graph gives all an idea as to where are you positioned and where are you at this point in time. Have a look at somebody who has got a wonderful flow. The flow is a high peak flow, a bell-shaped flow with a little prolonged curve. He passes at the speed of 25.5 and a residual volume of only 10 ml. He passes the exam and he's much above the pass marks from the lower graphs. Have a look at somebody who may have a small or a large prostate, but what are we busy measuring? We're measuring what is the performance of the individual through the urinary passage. And look at that. His flow is a baseline, a straining pattern, does not pass urine very well. If you turn your eyes to the right, he's holding 300 ml as the residual volume after passing urine. This gentleman may be complaining of a poor flow, taking time to start, passes with a dribble, passes with a very narrow stream, little, with an intermittency, stop and start, and finally thinks he has completed urination. That is how we have adjusted to over years and decades. At the end of it, when he comes out, the real result has come out. That's an examination hall story where the flow is poor and the residual volume is high. Now, he could be having a very large or a small prostate, but there is a bladder outlet obstruction, it looks like, and therefore we need to study. That kind of a flow pattern could also happen in diabetic cystopathy, in individuals who have a long-standing diabetes. That means their bladder could possibly be weak. The bladder may not be contracting and sustaining in one flow, as a result of which the urine could come out. And these kind of weak bladders result from various neurogenic causes of the spinal and the brain diseases, or various kind of injuries and traumas which could happen to the spine and the lower back. It could also happen in various brain diseases like Parkinsonism, multiple sclerosis, and various other disorders which happen around. So on one way, the bladder has a power to contract and the passage has an opening, allowing the urine to come out. But out here, we're looking at probably a picture of bladder outflow obstruction, a poor flow, which could happen because of the bladder outflow obstruction and the bladder is occluded. Or it could happen because hypocontractile bladder, which could be weakened by a long-standing diabetes, bringing about a change of diabetic cystopathy, or an occlusion or an obstruction, which is happening because of the prostate. So in individuals who don't empty their bladder completely, as seen on an ultrasonography, or who have got a high residual volume and they sense it or they don't sense it, a urologist takes it to a logical conclusion by identifying the performance across the bladder outlet. And that is called a uroflowmetry. The graph gives you all the idea compared to what he is as a good flow compared to what he is as a poor flow. With a good flow, his residual volume is as much as 10 ml, which is close to 0 to 50 ml. A good residual volume left over, which could happen to anybody in the background of a wonderful flow, compared to a high residual volume in a background of a poor flow or an obstructive occlusive flow, where you can see the graph starting and stopping continuously till the end, almost like a dribbling. And the graph parameters show that the pass marks are much below where he should have been. So when we look at that aspect, we identify that there could be prostates which could be small, but could still be occlusive. And that was what the matter was. So when we look at this gentleman who is undergoing a cystoscopy, taking a telescope and looking at the passage, as we enter the prostatic urethra, we find the prostate is occluding. It's trying to block the passage. And look at the bladder. The bladder shows the folds which are called as trabeculations. So as we enter the prostate now, there's an occlusion at some point in time. We're able to enter with a telescope, and the bladder has undergone those changes. These changes are called as trabeculations. As we examine the bladder for no other pathology, we assess them and remind ourselves of what we did in the outpatient department and the uroflowmetry. So this is an internal assessment where, let's look at him again. He has a small prostate on the ultrasound, called as 27 grams. He's not very bothered about it, but he's undergoing a progressive change internally. And that internal change has been assessed by ultrasonography. Let's revise this again. As the telescope goes inside the urinary passage, and that's the prostate, you can find an occlusion by the prostate, and then the telescope enters the bladder. As the telescope enters the bladder is visualized as undergoing a change where there are trabeculations, and the occlusion of the prostate is bringing about a change very gradually over years and decades into the bladder. That's an important aspect to be knowing, that the brunt is taken by the bladder, which suffers. The bladder continues to stretch across, partly by the habit that is progressively happening as a result of either ignorance or not being aware, or possibly able to adjust. So when we look at that kind of an aspect, we assess that we need to move to the next level, which is a smaller gland, probably as small as 19 grams, but could be bringing about an obstruction to the flow. This gentleman was getting recurrent urinary tract infection. Recurrent urinary tract infection always has a cause. So if an adult or elderly male gets a recurrent urinary tract infection, there almost always is an obstruction somewhere. Either a prepuce is obstructing because of a phimosis, a tight occlusive phimosis, or a urethra is blocked because of a stricture urethra. But out here, that was not happening in an adult who is actually a small prostate, but a very poor flow. Let's assess him by a cystoscopy. So we are right now in the urethra. We are entering the prostate under general anesthesia. So let's assess him as to what does it look like. When I take my telescope at the external sphincter zone, I'm not able to enter the prostate. This is a small prostate on ultrasound. The lateral lobes are not occluding, and I'm traveling across this steep bladder neck, or what we call as a median lobe. The median lobe or a steep bladder neck is not letting me enter the bladder. I come back and look at the strategies to enter the bladder, while the patient actually has got an occlusion to the entire aspect of flow. The flow is what matters to him. When we look at this aspect, we understand that his urinary tract infection, which has been treated again and again, is actually an aspect of completely treating him in a different level, while you understand that as you enter the bladder, you find all debris and dirt and kind of a thick pus. Aspects which are very important for us to understand, that when you don't empty the bladder, the urine could be sedimented and there could be debris inside. So once you enter this bladder, you get to know all about it. This is a patient who has got a bladder outflow obstruction, even though he has got a small prostate. So the prostate size, does it matter here, or does the bladder outflow obstruction matters, is a very important aspect to know. Let's move forward and assess the next level. The next level is a patient with a small prostate, but Look at the changes that may have happened to him. Let's assess him again. As a small prostate, he may not have bothered too much. He was not too much into agony. There were changes progressive, and he presented to his urologist with a possible poor flow, possible high residual volume on the ultrasound in an evaluation which happened. When we look at his aspects, let's look at a cystoscopy which is happening. The telescope is entering the urinary passage and comes to the prostate. At the level of prostate, the entry becomes a little difficult. And under general anesthesia, not being able to enter the prostate, entering with a difficulty, and finding the bladder being so trabeculated is a wake-up call. So let's come back to the prostate and enter the bladder with a lot of difficulty as it happens around. That's a prostate which doesn't look occlusive otherwise, but the median lobe or the bladder neck is quite tight. This is something which is occluding the urinary passage, and we enter with a lot of difficulty. We enter the bladder and assess the bladder. Have a look at this bladder. This bladder has undergone trabeculation. It's taken the brunt of a long-standing obstruction of a so-called small prostate. Look at that. As I move from one quadrant to the other quadrant in the bladder is thrown into multiple folds. As if the bladder has actually expanded, stretched, and has continued to stretch under long hours, long days and years, whereas the bladder has converted itself into a different kind of a cavity, which may lose its power of sensations and power of contractions. So these kind of bladders, which later on could turn a hypocontractile bladder, or a bladder which probably would lose its sensation internally and its power to contract and empty externally, is an important aspect for us to know. So the small size of the prostate is only a measurement by the sonologist. What happens to you is what matters. Is a bladder outlet obstruction could happen in a very small prostate or in a very large prostate. So that's basically looking at the bladder, and visibly that the bladder has undergone quite a change. Whereas the prostate, which is still very small, 21 grams measurement by a sonologist. Look at that prostate, which is just occluding internally, not so much by the lateral lobes than by the median lobes. In other words, this kind of a prostate deserves to be looked at more by understanding of the individual who is going through a change in the urinary flow. His flow is not poor, but his flow has gradually progressed over time. There we are. When we look at a poor flow, and we look at that the flow of urine is not good and he has a high residual volume, we understand that we're moving up the ladder to identify what is the cause of the bladder outflow obstruction. Is it the prostate which is causing an occlusion, or is it the bladder which is too weak, as I alluded to, in cases where a long-standing diabetes has weakened the bladder both sensation-wise and contraction power-wise? In situations of spinal diseases, in situations of cerebral and brain diseases, many a times the bladder may be weakened, and that weak bladder may turn out to be picked up only when the ultrasound shows a high residual volume, and we assess that. So whether it's a bladder outflow obstruction or whether it's a weak bladder, which is not letting the urine come out, is assessed best by a urodynamics, a multi-channel study, which is beyond uroflowmetry as the next step, where we look at the uroflowmetry graph, obviously, but we're also looking at simultaneous bladder pressures. Out here, if you look at the purple graph, the bladder pressure is contracting loud. When we look at the green graph or the uroflowmetry graph at the top, the flow is very poor, which goes on to show that there is an obstruction to the flow of urine. The bladder is crying but cannot empty because there's an obstruction to the flow of urine. And that's where urodynamics gives us the lead. Let's look at somebody who has a large prostate, and this is an occlusive prostate. He had an obstruction to the flow of urine for a long time. He was managing himself with medical management, but he knew that the flow is poor, and he lands up in an emergency with fever, chills, and undergoes finally, after evaluation, a TURP. So that's a prostate surgery going on, where the first chip is cut of an occlusive prostate, which was blocking the urinary passage. He has landed up with an infection, which has landed up with a prostatitis and prostatic abscess. That's where pus pours out when we start doing a TURP or resection to the flow. So as we resect and probably remove the prostate internally and carve a passage through which urine should come out. This prostate was large. It was 77 grams. This prostate was being treated medically. He was being treated medically, but if he did not get good results, or if he was too occlusive, or he was not getting the relief out of the obstruction, he could then be evaluated with a uroflowmetry with a symptomatology, and he could be given a timely cure in terms of a TURP. Out here, the TURP is happening for a prostatic abscess or an infection which has gone deep into the prostate, where the prostate has actually converted into a bag of pus. That's a prostate which is occlusive. So friends, the occlusive prostate is what matters. In other words, when you have a prostate which is occlusive or blocking the urinary passage internally, the urinary flow may be poor. It does not happen in an hour, week, day, month, or even a year. It's a progressive phenomena which goes over decades. And that change is something which we need to identify. As we identify this, we probably will be able to meet our urologist in time. That is what is needed. So while I come to the take-home messages on prostate and prostate size, what really matters is the awareness about the organ and the subject to all men. What matters is the prostate and what does the prostate do to your urinary flow. So if you close your eyes and imagine in a public toilet that you're passing urine and people are running away before you actually could complete your urination, or your flow is very poor and a very thin stream, it possibly is a bladder outflow obstruction. You must see your urologist in your city. What matters is the prostate size, which as it increases also brings about an increase in the blood supply. And that increase in blood supply could sometimes bring a spontaneous bleeding in urine or spontaneous hematuria, more so in the background of patients who are on blood thinners or antiplatelets. The medicines given by cardiologists for individuals who actually undergo angioplasty or undergo a cardiac bypass. Friends, evaluation helps a urologist identify you, which is more important. It is important for us to identify ourselves first, and therefore a urologist could take attempts at reversal, which is the need of the hour in the saga of progression which happens to everybody. Prostate cancer, which is another lineage that happens around, is treated by all of us as urologists. Your urologist knows the finale as to how to take it forward, either it's prostatic enlargement or prostatic cancer. So isn't it time to take prostatic health, even if it's a small prostate, to a final therapy, which is what is important.